Well, good afternoon, and welcome to Whitmix's webinar, Occlusal Excellence in the Digital World by Dr. John Cranham. I'm Bernie Jaroslaw, Whitmix's marketing manager, and I'd like to begin with a couple housekeeping items. First, you'll certainly see a questions box on the Zoom screen. Please feel free to type in your questions throughout the presentation, and at the very end, Dr. Cranham will answer the questions. Next, this webinar is approved for 1 hour of CE credit towards your recertification. You'll receive an email within 1 to 2 days or so that'll tell you exactly how it is that you have to be, that you will obtain your credit, I'm sorry. Lastly, the webinar is being recorded, so within about 2 days, it'll be up on the Whitmix website and in our webinar section and on our YouTube channel. So I now have the pleasure of introducing Dr. John Cranham. As an active educator, Dr. Cranham has presented over 1,500 days of continuing education all around the world. He was a partner and clinical director of the Dawson Academy from 2007 to 2020. He's published numerous articles on occlusion and restorative dentistry, and he's co-authored a book with Dr. Dawson called The Complete Dentist, released in 2019. In December of 2020, he partnered with Lee Culp to form Kranum Culp Digital Dental. Its primary focus is to accelerate the transition of the global dental community to digital technologies and workflows. Today, Dr. Cranham will show you some of the workflows that have transformed his practice, and that's all I've got. So Dr. Cranham, if you're ready, let's begin.
Yeah, welcome everybody. Thanks for coming in on a Tuesday afternoon. If you're out there on the West Coast, you're probably just kind of finishing up lunch. And I will say that it is a fun topic to be talking about today, and I have a lot to cover, so I'm going to go pretty quick. If you are looking at this later in a recording, I'm going to have my email up, so if you want to shoot me a question after the fact, you can just go ahead and email me or even text me. I'm going to leave you my cell phone as well. But I do think that, for me personally, this has been almost a 16, 17-year-old process to get to where we are now. And I had a lot of starts and stops with digital dentistry, but primarily because of all of my time with Dr. Dawson and really being in a situation where I did not want to cut corners. I wanted to be able to look at models in centric relation. I wanted to design occlusions the way I did it in the analog world. And it was very important to me that I wasn't just going to go digital. So as I looked at some of the earlier technologies, and one of the things that we just couldn't do was virtually equilibrate. We were seeing that with both CIRAC and with E4D earlier on. And it wasn't until ThreeShape kind of entered the picture in terms of the software that we'll talk about today that was a big game changer for me, because now, again, with the help of Lee Culp, who's my partner in our little business now, training business, but Lee was instrumental in really showing me a lot of the workflows that I'm going to go through today. And over the past about 3 years, it's just completely transformed my practice, because literally everything that I was doing in the analog world, I'm now doing in the digital world, but doing it faster and quite frankly, with less error. And it's just added a ton of fun and predictability and efficiency and profitability to what I'm doing. Dr. Dawson once said, digital dentistry, in the absence of sound occlusal, aesthetic, and restorative principles, will only allow a dentist to screw up mouths even faster. And while that is hilarious when he said it probably 10 years ago. And again, our concern at that time was that we were seeing people going digital for digital's sake, but some of the things that we're going to get into today that are related to occlusion and are related to really good sound aesthetic principles just were being ignored. And, early digital dentistry was really about just spitting out a widget to cover a tooth. And we're so far beyond that. So the goals of this webinar is I want to teach you how to get the most from your intraoral scanner. keys to obtaining great intraoral scans if you're scanning. And I also want to show you how a couple ways that we can scan in Centric Relation. I want to teach you how to utilize software to mount virtually in Centric. And I'm going to go through the ThreeShapes protocols that we're using to mount cast in Centric Relation on a articulator in literally minutes, how we can perform trial equilibrations today, and a little bit of how we design stable occlusion, occlusal schemes with the same goals of lines in front, dots in back as we did, for all those years in the analog world. Going to show you how we can do a diagnostic wax up, and that we're not actually waxing, we're importing teeth and scaling and bringing these beautiful contours that a laboratory technician has already done. So it allows us to get teeth in position in an amazing way. I want to talk a little bit about printing and show you how that fits into a practice so nicely. I want to get into a little bit on the return on investment, because it isn't inexpensive to go down this path, but where I really think that it pays for itself very quickly by mastering these digital workflows. And then I want to talk a little bit how to get started in the what I call the sort of the transition to digital decision, which is combining hardware, software, and training, the HST decision that we have to make. And it's a tough one because there's so many decisions out there. I have had a good time working with the Whitmix product, and we'll talk a little bit about the Vera 1 digital workflow. And I do think one of the things that they are doing extremely well is understanding that, intraoral scanning is one part of it. Certainly having access to software where you can do things for the scan. A lot of people think you can just buy a scanner, you can automatically print models. That's not how it works. There has to be something in between. And if you're wanting to do things like design splints or surgical guides, or look at casts on an articulator software as a part of it, 3D printing actually is inclusive of a printer, resins, some sort of washing station, and then a cure box. And so this is sort of one piece of it. But again, in the middle of all these things that they're doing is this support team. And I do think this is one of the things that does kind of separate Whitmix from a lot of places, is I found the support to be really, really good. There's certainly basic training with all of this. And again, what I feel like that Lee and I are adding to the piece of the puzzle that we're adding here is training we'll talk about at the end of the seminar, but giving people the expertise to get the absolute most from their software and be able to do that in the privacy of their own home, or be able to train their teams or whoever. But, getting what I say sucked down the rabbit hole of really diving into this digital world can be a little bit intimidating. So you got to have good hardware, you got to have good software, you have to have good support, and you have to have good training. What it leads to is pretty cool, though. This is my little workbench in my office. I used to have a waxer there and models on a stone articulator. I did that for almost 30 years. And now we have 3 screens. And on that far left screen, I can be looking at our photographs real carefully, looking at the static images of the models from the scans is very, very important. Certainly today, cone beam, we're not going to talk about cone beam today, but 3D imaging is changing the way we look at joints and the jaw and infections and, wisdom teeth and implant sites and all those things. And then of course that top screen is what the ThreeShape Premier software looks like. And when I say ThreeShapes, I'm not talking about Trios. Trios is a great scanner, but I'm talking about the ThreeShapes, either Premier or the complete restorative software that laboratory uses that we'll use to make things. And we can use that same software to do our mountings, to do diagnostic wax ups, to make your own appliances, to print models with their model builder. And that is the software that really has changed everything. It is crazy what we can do today. And the other piece of the puzzle is going to be working with laboratories that we're also going to be doing some training with along the way, Lee and I. Lee's lab, Lee Culp's lab, Sculpture Studios, is a 100% digital lab. And this is just a nice example of a digital denture of where we went pretty much scanned, designed, took the teeth out and put the dentures in. And so we really do have unbelievable control with some of the things that we're going to talk about today. So number one, let's talk about getting the most from your scanner and getting great intraoral scans, and then go into CR a little bit in terms of how we're going to scan in centric relation. And that allows us to then move into some of the virtual articulation things that we can do. The first thing I want to talk about is just if you're scanning, usually the first thing we do with the scanner is we start scanning single tooth impressions. If we're doing a crown, just prep a tooth, you want to take a scan and take it instead of using your PVS or polyether. And the thing that we did for a lot of us were trained on with conventional crown and bridge was a 2-chord technique. And the purpose of the 2-chord technique is you'd put a small cord down into the base of the socket, or I'm sorry, the base of the sulcus. You'd put a larger cord on top, let it sit. You'd maybe pack this with viscostat or hemodent or something to hold the tissue out of the way. And then you'd pull the top cord. And the goal was that when you squirted your impression material in there, the impression material would pass about a 0.5 millimeter past the margin. And the reason you wanted to go past the margin is when the lab had a stone die, they could easily trim away the outside of the stone and see your crystal clear margin. The problem with this technique with scanning is while this will work, it may not be necessary, because the scanner is never going to see the vertical walls of the root. It only needs to see the margin from the top. It's line of sight completely. So my tip to you, if you're scanning, is to use one cord, or you could even use a laser if you want to do a little tracking that way. But all we really need to do is put something in there and just push the tissue out of the way so that you can see from this view looking down that margin 360 degrees around the tooth. This is a good example. Just simply getting it out of the way so when you take that scan, looking down the long axis of the tooth, it's crystal clear there. And so my tip is use a larger single cord when scanning for crown and bridge. Lasers are helpful. If you've got an electrosurge, not too many of those around, but just line of sight. Again, looking at another example, single cord, looking 360 degrees around, that is really pretty much, that's all that's needed. So we want to make sure that we keep the site bone dry. Triangles are important. Keep that saliva ejector in there, but you want to keep the site bone dry. Water, while you can scan through it, will distort things. And so you want to make sure it's dry. Again, use that single cord large enough to push the tissue out of the way. Remember, it's possible for the tissues to be pushed back, but kind of hanging over. So if you have a margin like that, if you're looking through the long axis and you can't see the margin, you got to figure how to get it further back. So either another cord, or you're going to take the tissue away with the laser. But line of sight is what you want to remember when you're doing that. That is the absolute key. The other thing that we want to recognize when we're scanning, and all scanners are going to be a little bit different. They all have their own little nuances. So pay attention to what the people that are training you are saying. We've got experience with CERAC, with E4D, with CareStream, with iTero, with the new Veripulse scanner from Whitmix. We've got all those, and they'll all allow you to get great scans. But they all are a little bit different. And so what we really want to talk about for a second here is just sort of best practices that we do with all of them. So let's talk about that. And the first little tip is use these little opter gates from Ivoclar. They're fantastic. They're vinyl. They have one little inner ring and one large outer ring. And when you pop them in, it just holds the lips out of the way. So For somebody working by themselves, it really helps get the cheeks and everything out of the way. So use the OptraGate. The other thing you want to do is, again, along with following what the scanning companies are telling you, you want to make sure that the person scanning is spending most of their time looking at the scanner and not inside the mouth. They want to get used to being able to roll that across the teeth and gather the data while they're looking at the screen. If they're just spending all their time looking in the mouth, they're really not sure of what data they're collecting. And the other thing you want to train them on is to gather all the data. Don't make it a race. They should be able to scan an upper arch with the palate and, you know, the height of the vestibule. In a minute 10, you know, they can do the upper and lowers pretty easily in a couple of minutes. You can go faster than that if you eliminate things, but we want to get as much data as we possibly can, just like in the analog world when we were taking alginates or polyvinyls, that we got all that data. Okay, so that's kind of, no matter whether you're doing diagnostics or crown and bridge, those are good best practices techniques. So let's talk a little bit about getting centric relation and just show you what we're going to do here. Now, this is going to show you a leaf gauge method. And the first thing we're going to do is just get one bite in maximum cuspation. So we're just having the patient bite together. And most of the softwares will allow you to do 2 bites. So as we go in there, we're just putting maximum cuspation for the first one, and we're going to confirm that. And then the second thing we're going to do is now use a leaf gauge and to take our second bite. So that's, again, they see the arches come apart. I'm going to slide in behind the patient, get my little leaf gauge in there. And you just want to have enough leaves so that the back teeth are apart, definitely not touching. And to deprogram them, you know, we're going to have them slide back and forth a couple of times on it. We can have them squeeze, do some basic load testing to see if there's any soreness. And you may want to do this for a little bit, but when you're happy with that, just have them squeeze on that, make sure the jaw does not pivot around, and now scan the alignment. Now, what you'll see is when we import these scans into our ThreeShape software, that alignment is going to be maintained. So mounting, as you'll see, becomes an absolute breeze with this. So that is really, really cool. Now, the other way we can do it is with a more traditional bilateral or bimanual manipulation technique. Like for you Dawson people out there, this is how I was trained. A lot of you were trained. And what we can do is go ahead and take a little ball of composite and put it over the teeth, and now go back to our bimanual manipulation. And we're going to do our 3 increments of loading and then cure it right there. So once it's cured, whenever that patient goes into that little resin button, the patient's aligned in centric. And now with them closed on that, just like with the leaf gauge, we can scan from the sides. And we're again scanning the alignment on both sides. And when that scan locks in, it is in CR. This is an example of doing CR first, now just taking the maximum and cuspation bite last. Generally speaking, when I'm taking a CR bite, I also do the MI bite because I just like to compare, and you can really see, you can toggle between the 2 bites and show a patient potentially a discrepancy between CR and maximum cuspation. So just keep that in mind now, and we're going to start talking about virtually mounting now and performing a trowel equilibration. So this is what a ThreeShape articulator looks like. It doesn't have to be the Whitmix Mark 320. You can have a Stratus, you can have a Sam, you can have whatever you want in there, Hanau. The point is, though, what matters is the mandibular movement. So you don't really need to have the articulator there. It just makes us feel good. We have the ability to change the condylar axis and the Bennett, all the things that we would do in the analog environment. But what we do need to do is mount the maxillary cast. Now, we don't have to mount the mandibular cast because the mandibular cast is going to come in wherever we scanned it. And again, no wax, no stone. That's where we save so much time. So what we're going to be utilizing now is our ThreeShape Premier or complete restorative software to get that done. And in our practice, what our workflow is we'll typically do the exam. I'll determine how I'm going to get the bite, either with a leaf gauge or a ball of composite. Then I get out of my assistant's way and they can get photographs and scans and do all the things that they would normally do. But once she gets the scans will go up into the cloud. And then my son, who does some of the laboratory stuff for us and the digital stuff for us, will grab the scans. And this is him working on it. So the first thing is that ThreeShape is a software that's designed to be used by dental laboratories. So you're basically filling out an order form. We show you how to do this in our training, like specifically what you're going to do a virtual mounting or a diagnostic wax up or shell temporaries or toppers or whatever you're doing. It's important to know how to fill this thing out properly, because this is what is telling the software the teeth that you're going to work on and the things that you want to accomplish. So order form is going to be filled out. He basically told us we're going to do a virtual mounting. And now he's grabbing the scans and bringing it into the software. So he's bringing the upper jaw in first, the lower jaw in second. And then the software will start to open. And once it does, the first thing that happens is the maxillary cast will be hanging above this platform. And what his job is he's going to go ahead and grab that maxillary cast and align it with this platform. And when he gets those central incisal edges sitting on that platform like that, on the virtual articulator, that is now positioning the maxillary incisal edge 100 millimeters from the condyle on the virtual articulators, what we call Bonwell point. It's the same distance that is used on the Coyce face bow, for instance. Bonwell point is something that's been around a very, very long time. It also, when it's on the platform, it's basically making the maxillary cast level with that platform. And I'll show you later how we use photographs to determine whether there's a cant in the smile or not. Because again, if you just trust this, if the maxilla is hanging in the patient's head like this, it won't know that. But we can alter that later, and I'll show you that when we do our wax up. So once he's got that done, he pretty much is going to now bring in the mandibular cast and click on the articulator button, and that sucker's mounted. It's that fast. Most of the time, this is basically real time. It's a couple minutes. I just want you to think about in the analog world, the time it takes you to get there and how fraught with error that process is in terms of alginates or polyvinyl or pouring stone and mixing the stone. Are you using a vacuum mixer, trimming the models, mounting the articulator, mounting on the articulator, mixing the mounting stone, all that stuff, the wax, did the wax warp, did it break, all those things. This has saved me literally hours of time. Now, the question is, if this distance from here to here is 100 millimeters, is that good enough? How does that compare to the ear bow, which what most of us were utilizing? Because I lost sleep over this. I thought a lot about it. And then Drew Cobb, who somebody I taught with at Dawson, who also has made this transition to digital, found this article that was in the Journal of Prosthodontics in 2015. And they compared the ear bow with the Coyce face bow, which is based on the Bonwell point. And they basically varied by about 10 millimeters. We got to remember that ear bows are also based on an average, and not very many of us are utilizing a hinge axis. Now, if you wanted to be more accurate, you can bring a CBCT scan and superimpose it over these articulators. There's face scanners, there's all these different ways to do it. But I am all about trying to keep the cost down. And what I'm finding is that, and now with 3 years, is this is more accurate day in and day out than what I was doing in the analog world. There's just less chance of error. So to be clear, what we're going to be doing is mounting the maxillary cast in ThreeShape, utilizing this Bonwell point of 100 millimeters. We mount the mandibular cast simply by bringing it in. When it appears, it is going to be in the alignment of however you took the buccal bite. So if you scanned in CR using a leaf gauge or a button of composite using bilateral manipulation like I showed you, you will be in centric relation. Your cast will be mounted in minutes, and the best part is no melting wax and all the things that we did for years that I was very, very proud of. This is just better. It's easier. Now, let's look at performing a trial equilibration. Now, again, when you're on the virtual articulator, I've turned the articulator off, but what I want you to see is right here, we have the capacity to change the condylar inclination. We can change the bended angles. I've got 34, 34, 10, and 10. And we also can open and close the articulator by pushing the up and down arrows. And it will close on the arc, just like how the patient moves and just like how an analog articulator would move. What's different about it is that these scans are basically shells, all right? They are a very thin, I want you to imagine a 5 micron mesh. So when you're sitting open at the first point of contact, if you close down the articulator, what happens is the mandibular cast will penetrate through the upper cast. It's really cool because if you're sitting at the first point of contact and it's open in the front and we close down that articulator, what we want to know is we want to close this down until we see the front teeth touch. And then if we look at the back, we can see how much of the back teeth penetrated through. In other words, how much would we have to cut off, trial equilibrate, or actually equilibrate in order for the front teeth to contact. That's the way we get equal intensity contact. So let's just go through that exercise. And to help you see it, what I want you to look at first is we're going to turn this upside down. So I'm looking through the upper cast, and I want you to look over here now. I'm starting to close down the articulator. The gray is starting to come through. So let's just play it. Notice how we're opening. Now we're going to close it. Notice how the lower teeth start penetrating through until the front teeth start to contact. Watch it close again. The front teeth are starting to contact. And what I'm going to do once I'm there is I'm just going to lock that down. That locks the vertical. So now we're basically have closed it until the front teeth contact. We lock down the vertical, which is their vertical at max intercuspation. And now we can analyze to see how much tooth structure needs to be removed. Now, this is the cool part. If we want to do the trial equilibration, we can go in here and just like we would with an articulator, articulating paper, we'd mark it. And then with a little hand piece, we'd start reshaping. And what you've seen me do is I'm reshaping the mandibular teeth right through the upper teeth. And I'm taking it away until I just see a little tiny pinpoint. Now, we can do the trial equilibration on both arches. That's, if you want to flip it over, this isn't much, so I'm just doing a little bit of it. But once we've gone ahead and done that, we can then take the upper cast away and then look at the mandibular teeth to see if we've done too much destruction. Here again, this takes me so little time. I can often just look at that and not even need to do a trial equilibration. I can tell how much tooth structure is sticking through to tell me if I feel comfortable with that or if perhaps we need to move teeth. Digital design on full mouth rehabilitation type cases are equally as, let's see, back up one. Yeah, here we go. Are equally impressive in terms of our ability to really look at excursive movements and do our design appropriately. So if we want to take away the cast and just analyze things, we can see where things are interfering. This is a good example of a working interference you're seeing on this premolar. And if we wanted to adjust that, we could start adjusting that line just like we would on a model. But notice how the mandibular movement is still occurring. We don't have to stop and re-mark. as we take away that working interference, notice how the line is being created on that canine. So our ability to dial in occlusions very specifically is really, really cool. Similarly, if we want to dial in an anterior guidance, you know, if you're trying to pick up a little bit more of the distal, the laterals, we could grind in this area or reshape in this area, and you'll start to see the lines become more pronounced on the distal. All the things that we did in the analog world, we can do in the digital world to get to this point where we have achieved that goal of lines in front, dots in back. The principles that we've learned in the analog world don't change. How we apply them do. Let's look at now doing a functionally correct diagnostic wax up, and I want to take you just through a case and how we look at things. And it's just going to be an 8-unit case, and I want to introduce you to a little treatment planning acronym that I call FACEAD, and FAESAD. The FACEAD method is just a way for me to work with my clients to keep them on track when they're doing their design, so they remember the things they need to look at. And so just to look at what FACEAD means, the first F in FACEAD stands for the acronym FAB, or face airway bite. So this right here is face airway bite. We want to look at the face to make sure we have something that's aesthetic and is going to be in the proper position for a good airway and good alignment for a good bite. The A in FACEAD stands for arch form. We want to make sure we have a nice broad arch form. That's also kind of upper airway, has to do with air going through the nasal passages, as well as how things align from a cross-bite type perspective. E stands for edges. We're going to be looking at the incisal edges of the lower teeth and the upper teeth. S stands for stops or contacts. This also is when we look at vertical dimension, but we want to make sure we have equal intensity contacts all the way around. The A at the end of FACEAD is anterior guidance, and the D is disclusion. We need to think about all these things when we're doing our global treatment planning and designing. So let's look at Chrissy as an example here. Great example, attractive young lady. She's actually my office manager in my office. She was kind of interested in doing something to her teeth aesthetically. She felt like her centrals were kind of big. She had a little bit of crowding on the bottom. Also had a little mild wear, had some sore muscles from clenching when we did her exam, but nothing too significant. Definitely just some functional things going on, but nothing that's messing with her life. Definitely more aesthetically driven. But we look at her pictures. Again, she does have smaller laterals, a little bit of gingival inflammation. Don't like this crowding on the bottom, particularly that lateral. I'm doing veneers up top. I don't like one lateral sticking out like that. Again, proportionally, you can see what we're talking about. This lateral is almost, this should say the central is almost twice the width of the lateral. And remember this, if this is a value of 1, this should be about 1.6. So things are off a little bit. Length of her teeth is pretty good. Horizontal position isn't bad. There's her maximum cuspation. Class 1 in MI. Little irregularity to her incisal plane. So even in this digital world, we're still analyzing tooth position the old way. We're now going to scan her in Centric. So we take our scans, we mount her and do a scan in CR and in MI. And this is her CR scan. What I want you to see is there's CR, there's MI. This is the beautiful thing about taking 2 bites like this, because we can really show the patient where they're hitting. And that slide is driving the mandible forward and probably creating some of the crowding that we're seeing in the front here. Arch forms also look a little bit narrow. So we're going to take all the pictures and go through some sort of an analysis to get a basic idea of where we go. And one of the really cool things within the software inside of ThreeShapes is this digital imaging kind of next level, where we can start analyzing things, and then bring in the a proposal of tooth form and tooth contour and start playing with it. This leads us to something that where we can sit with the patient and show them different shapes, which potentially even gives us something we can kind of go through and just have a look at. So we'll get into this a little bit more detail, but I really like looking at it from the standpoint of just looking at the size of teeth and seeing that, you know, those centrals are pretty darn wide. And so we've got something we've got to think about here. We also mounted the cast and did that trial equilibration. We closed it down and I flipped it upside down and looked at it. And I could tell really quickly looking at these collision lines, this is pretty much how much tooth structure I'd have to grind away. It was just too much. I felt like she could use, if we could get a little intrusion of the back teeth from aligners, expand her upper to create some width on either side of the lateral, straighten out her lowers, she could really benefit from Invisalign. And so that's the direction we did. We biologically just had to do some recare. For functional stability, we're doing Invisalign, phase 2 records, and a wax up. We'll do equilibration, and then we're going to do 5 through 12 minimal prep veneers and then final retainers. So let's look at the Invisalign. Again, a great digital workflow. Expansion that occurred, we were utilizing just 12 trays to get that done, so making it broader. We look at the lower teeth here. They're going to be much straighter when we're all done. It looks great where she was and where she's going. Good expansion up top. There's from where she was, where she's going, and creating the space for the laterals. So 12 trays, we do 1 tray a week. So 12 weeks later, this was where Chrissy was. This is where she ended up. You can start to see a little bit more of the premolars in the back from the expansion. And again, some width on either side of the laterals, be able to build them up. Much more level, lower incisal plane, which is going to be great. And we've gone ahead and socked this into class 1. Here's the space for the bigger lateral that we'll be able to put in there. You can see the expansion on the right in both of these. And so now we're going to go ahead and do phase 2 records again. So you're probably interested. Here's your scan from NCR before Invisalign, and that was too much to equilibrate. But look at this one down here. Look at her scan post Invisalign. There's still a slight slide, but it is a lot less. And this is something that I could absolutely equilibrate. We're also going to go ahead and do that digital design and figure out exactly where these teeth are going to go now. And I can kind of sit down with her and with the slider show her what we're thinking about. This design can then be brought into our ThreeShape to do the wax up. Now, one of the things we can do with ThreeShape in the Premiere software is superimpose her face over the articulator and pay close attention to the embrasure, and then look at how our cast is mounted. And then we can make the tooth translucent, and we can start playing with this to make sure that that maxilla is hanging on the articulator exactly how it's hanging in the patient's face. And this is how we check our alignment. This is exactly how we do it. And this becomes a very, very easy way for us to work. We're now going to go ahead and do our trial equilibration. I showed you this already. This is the one that we actually looked at. So we closed her down to that first point of contact and then took away the interferences. So we're going to get those stops taken care of first through ortho and equilibration. And now we can start positioning the teeth accordingly. So when we're waxing, we're actually choosing from a bunch of different types of sizes and shape, potential contours of teeth. And when you bring the teeth in, the virtual teeth, they pass through the cast just as if like a denture tooth could somehow just pass through it. It's like a a stock tooth you can bring in there, and then you can scale it. So when we're virtually waxing, we're not actually waxing, we're scaling teeth. And the more you can do that, watch me get the central exactly how I want it, and then I'll copy it and send it to the other side. Then we'll work on the lateral. And so in this way, we get the facial contours exactly how we want it. And we get that one sorted out. We'll copy that tooth and send it over to the other lateral and then get it in position. So this becomes a really, really fun thing for us to do. Once we get that dialed in and they're happy with it, we can then turn our attention to the function. We've already equilibrated, so everything's closed down. So now it's just a matter of confirming our guidance. And this may require a little bit of adjustment in the back or fine tuning our restorations in the front, but that's starting to look pretty good. When we're happy with this, now all we're going to do is print this. So having the ability to print a model and get this kind of detail, this type of anatomic form, I would have had to spend hours doing this. And this whole wax up probably took me about 20 minutes. Once I get good at it, an 8-unit case, you can wax up pretty fast. Some of our doctors we're coaching may take a case like this and just position the two centrals and let a lab finish it. That works too. But we'll still make our same matrices. We'll still prep the tooth the same. That silicone index of the wax up we can bring in and fabricate a provisional restoration. And just like in the analog world, that wax up's our best guess. And so now we're going to fiddle with this until we're happy with it aesthetic, phonetically, and functionally. And then we'll scan the temps, and that will become the blueprint for our permanent restorations. But looking at pre-op, post-Invisalign to now provisionals, we're pretty happy with that. So now we go to our final restorations, which are going to be EMAX. This was done by Barb Warner at Night Dental Lab. And what she's done is just taken my scan and basically copied it in the final restoration. And the rest of the way, and the next is just dialing in the occlusion. Okay, so that's diagnostic waxing. Now let's do some printing, and looking at printing, and again, understanding that printing is the compilation of making a decision of what printer you want, looking at resins, the different resin type of things for surgical guides or provisionals or bite splints or models. There's different types of resins. Once it's printed, having a wash station where you don't have to get messy, and then curing the resin, a cure box. A couple different types of printers, and these two here were next door at Bayview Dental Lab, the Asiga printers. These are really good, solid workhorse printers. We'll talk about them in a second. This is my little Whitmix printer, which is an LCD printer, which has been great for me. But understanding the different type of printers, the SLA printers, or the stereolithography, was really the first generation. Not too many of them around anymore, but the ones that you need to know about are the DLP printing. And I want you to think faster, broader spectrum, very accurate, but more expensive, like the Asiga. A lot of labs use them. These DLP printers, think they're a little bit slower. Newer models have a broader spectrum. I'm getting one of the new ones from Whitmix here soon. Very accurate and less expensive because the technology is almost like what's based on what you see on an LCD screen. You know, when you think about what you're going to use it for, I thought initially that I was going to need a great big printer because I was going to be printing all of these diagnostic models. But in reality, what you realize quickly is you don't have diagnostic models because everything's in the virtual world. The only thing you print is a wax up once the patient says yes. Or you might print surgical guides, or you might print orthotics. Right now, my printer won't do the resin that does the TMJ orthotics. So I design my appliances, send the file over to Bayview, and they print them for me in the Asiga. So printing, I think, in my practice, more and more we're going to be printing the things that we do. So if we take a case like this, just a big old wear case, all sorts of erosion, it's got some perio issues, going to need some grafting. You know, we can take a case like this and do all of the positioning of lower incisal edge, upper incisal edge, look for that vertical and stop. So we're going to start dialing that in, start really getting the stops where we want it, working out the disclusion. So all the things that we would do, even on a very complex case like this, but once we're happy with it, we can create a model that we can print and send this file. This comes from Model Builder. This is a part of the ThreeShapes program and Complete Restorative, but that printer now can print that design. And when it comes out of it, it's just magic. It's that, you know, that three-dimensional visualization that you saw. Again, the wash station is important, and this little Vera wash station is slick because you can take the build plate and it drops right in there and you don't have to touch anything. Big change for me, because when I first started printing, I had a bottle of alcohol or the isopropyl alcohol, and I was squirting it, and you know, I had gloves on and masks, and this is just clean. We can just set it for the mode, how long we want it to wash, and start it, and then we put it into the next one. From there, it's a simple matter of just letting it dry for a minute and then dropping it into the cure box. And again, what I just want you to see is the detail. I mean, that anatomic form is beautiful. Make our silicone matrices, transfer that into his mouth, test the new vertical, incisal edge position. He's gearing up to finish the upper and have some grafting done on the bottom. And when it's all said and done, it looks great. Okay, a lot of things are done the same in terms of how we execute, but what's radically different are the workflows to get there. So much more efficient. And again, that provisional phase of having contours like this are pretty amazing. So where is the return on investment when utilizing digital workflows? No question, it comes from time saving and increasing predictability. If you're wondering whether it's accurate enough, this was a study in Clinical Oral Investigations in 2021. Intraoral scanning reduces procedure time and improves patients' comfort in fixed prosthodontics and implant dentistry. The iOS is faster than conventional impressions, can improve the patient experience, and iOS as part of a digital workflow is able to provide reliable prosthodontic outcomes. And so it's important to know when you sometimes are comparing what happens on like steel dies outside of the mouth, you may see that polyether is 10 microns better than a scan, but is that clinically significant? What I can tell you is the fits are unbelievable. And we've been doing it scanning now a long time. Consider this: Invisalign production team notes a 4% rejection rate with poly PVS impressions compared to 0.4% with intraoral scans. That's a huge difference in terms of getting things coming back. If we're comparing digital and conventional impressions, John Burgess, somebody I really respect at UAB, along with Augusta Robles, digital impressions offer advantages over conventional impression materials. Again is saying that this is a very viable option. Wants to have some more information, but from what he's seen, it is creating a better clinical experience and is adequate. In other words, it's giving you enough clinical accuracy to be able to do a really good job. And so that's kind of been my experience. If I can have a better patient outcome, I can be more efficient, and it's clinically the same or better than when I was getting analog, that's when I shift. If we consider time the old way, FaceBow, impressions, wax bite, pouring models, mixing I took these videos, I made these videos for Whitmix, in terms of mounting on an articulator. Spending the time to get this sanded. This process takes hours of time and is fraught with error. Trial equilibration, similarly. I mean, this is how we did it. You had to sit there and adjust all the back teeth until the front teeth touch, and then you looked at how much tooth structure was how much tooth structure was removed. Now the back teeth just penetrate through one another. We can look and analyze to see if we think it's too much and go another way, like I did with Chrissy's case. We look at waxing to be able to do this. I mean, this is what we did, but it took a lot of time, and the anatomic form, if we're honest, just wasn't great. So if it's better looking and it can be created in less time with increased accuracy, is there really even a choice? The 6 in how to get started is what I call the HST decision, which is basically the hardware, software training decision that you've got to think about. So to set yourself up for success, I've learned a lot from working with these doctors over the past year. You know, what Lee told me all those years ago was, you know, pay the price to learn and use the hardware and software, get training and block time and practice. It's the only way. And so I would drive down to Raleigh and drive Lee and his team crazy to try to learn these things. And then I just spent hours in the software making mistakes. Part of our training is, if you want to go down this road, is to not have to bump your head so much in the process. I'd say involve your team once you're comfortable with the process, but be okay with changing rapidly. This was a meeting we had with Drew Reingold, who's a really good digital guy, and he was teaching us about mesh mixers so that we could print models to mount on an articulator. It's like 3 years ago. This is like our first little transition. And we were listening to every word, and you know, here we are 3 years later, and we're no longer on an analog articulator anymore. But that's okay, because that's the culture of our practice. We're always going to be looking for a better way. Create systems to track your work. Lab pans will be a thing of the past. This is just showing you a little video of my little area behind my desk. And if you notice, there's my computer for the design, there's my printer, and in between, we had some lab pans. Well, the problem with lab pans is nothing goes in them. And what we noticed is when we would need a case to mount, it would just go up into the cloud and we'd forget about it. So we replaced it with this magnetic board where when we start a treatment plan, the little magnet with the patient's name and the mounting goes here. Once it's mounted, if we have to a splint to fabricate, it'll go here. And once it's mounted, my son will move it over to here where I have to treatment plan the case. You can see I'm a little behind. Caitlin's pink and I'm green. Once we've treatment planned it, goes over here and waits for consult. And if the patient says yes, then the design goes on to printing either at Bayview or in-house. That's our process. That's our workflow so we don't get lost. Get quality hardware and software that you'll want to work with. Think about what scanner you want, what printer you might want to work with, what sort of software you want to look at with virtual articulation. I'll tell you, there's really two. There's ThreeShape and there's Exocad. I chose ThreeShape for a lot of reasons. I'm happy to answer that question. But one of the biggest things was I just like the teeth in it better. I like the contours. I like the ability to do aesthetics, and don't underestimate support, because you're going to have problems with the hardware and the software, and you want to be able to get to people to help you. So when I think about what Whitmix has done, what impresses me so much for a team that was really based in the analog world forever, they sold articulators in stone, for Pete's sake. They've jumped in with both feet, and they've got the VeriPulse scanner. They're aligning with and distributing the ThreeShape software. They have the VeriBuild printer. They have their resins. They have the VeriWash station, the curing unit, and then they have an unbelievable support team. And so what Lee and I are excited to do is to partner with them as far as the training. Last year, I kind of had a proof of concept with 25 doctors in this Kranham clinical coaching, where we had doctors that bought the software and did this online training. and it's very successful. And what this is transitioned into now is the Kranum Culp Digital Dental, that is the same training with a lot of other things. Our mission together is to accelerate the global dental community's transition to digital technologies and workflow, and we will do so while increasing the efficiency, predictability, and quality of patient outcomes. So that's it. That's what we're focused on. So whether it's working with the dentist, the dental team, a company like Whitmix, we're going to look at it from all angles. The flagship for us is this subscription-based online training, which we'll talk about in a second. But typically, the typical doctor will buy the software. They may get the scanner and the package, the whole package that Whitmix can talk to you about. Some people have their own scanner, and they may do our training and buy the software and say a printer from Whitmix. So there's different ways you can do it. We do have hands-on digital immersion classes at Lee's facility in Raleigh. Our clients get a 25% discount on that. Included is 6 half-day online lectures. So we do that as part of it through Zoom. We have an online community through WhatsApp that our doctors communicate and share cases and ask questions. And this has been invaluable because when you're learning this, you get stuck. And it's cool because people put their question out there, and before I can get to it, other members in the community are helping them. We're working towards having a digital symposium, get past COVID. It'd be really fun to have this community meet once a year and have different speakers. And then the other option that people will do is one-on-one coaching with me. And that's a little bit limited because I can only do so much. But we do the training through Teachable. So it is a robust platform where you basically can choose what it is you want to learn that day, whether it's mounting or we have several different cases like opening bites and veneers. And then you can sit there and follow along with me. You'll have the same models that I'm working on. This is Noemi, is one of our stars in the program, working along. This is really changing, I think, the potential for people learning, not having to get on planes, and really being able to dive in and implement something in there. So again, I think your transition to digital decision is this HST decision. And I want you to think about this is take a lesson from Stephen Covey all those years ago, but begin with the end in mind when planning your transition to digital. What do you want your practice to be? Are you more implant oriented? If you are, you need a CBCT probably and a scanner. If you're more crown and bridge, if you're doing a lot of TMD, definitely probably want a printer as part of the package. But think about what it is that you're doing. We are at a point that everything we could do in the analog world can now be accomplished in the digital world with increased efficiency and equal accuracy. Choose hardware that works well together and make sure you have access to good support. Ask that question. If you're looking around and comparing, find out about support, talk to other people that are utilizing it to ask that question. And then don't forget to focus on software and training so you can easily master the workflows that will drive your practice. Gone a little bit longer than I wanted to, but I think we got through a lot. Here again, for the people that are watching this and recording, that is my cell. I don't really mind answering texts. If you have a question and you want to text something to me, if you have interest in what we're doing training wise, or any questions, you can text me and we can go from there. So I'm going to stop my share right there. I think we may have a few questions and go back to Bernie. And Bernie, you can fire away.
All right. Well, I appreciate it. Thank you so much for a truly wonderful program. That was excellent. I learned a lot myself. I enjoyed it. So if the rest of you have enjoyed it and you've enjoyed learning about clinical digital dentistry and would like to learn about maybe how you can get into it or get into it more than you have already, there's a poll up on the screen right now, and all you need to do is check yes. And if so, we'll have a Whitmix representative contact you soon. So that's a good way to learn more about the things that Dr. Kranum has spoken about. And you can learn about the equipment, software, and our training and technical support. So please take advantage of that. Also, I just want to remind you that the webinar is approved for 1 hour of CE. You'll be contacted within a day or two at the most, and with a thank you letter, and it'll explain exactly what you need to do to get that credit. The questions I got, and I don't even know how to explain this, but the only questions I got, at least so far, we got some thank yous, but is about the recording of the webinar. This was recorded, and it takes about a day, maybe 2 at the most, and it will be up in the webinar section of the Whitmix website, and will also be on our YouTube channel. If you go to YouTube videos, you can watch them there. And that is it. No, we have one question just popped up. Okay, first actual question. They're coming in. I have a Centric milling machine, but I'm looking at the Plan Mecha Plan mill. This comes with an Exocad software. Doesn't
I
seem
don't
like
know.
a question.
Yeah, I don't know a ton about Exocad and mills. That's something that I'm not doing in my practice. But what I would say is, again, when you're thinking about big picture, I think our mistake in any digital decision is we often get locked into a specific scanner, or a specific mill, or a specific whatever, and then everything else goes from there. And a good example is, if you're looking at that mill and it comes with the Exocad software, the software is probably more important than the mill. I hate to say that, but you're going to be designing things in the software. So you need to look really hard at the Exocad software and compare it with the ThreeShape software to make sure that that's what you want to do. I personally, again, people disagree with me on that, but I looked hard at both of them, and I thought there were a lot of advantages to the ThreeShape. Particularly, my practice is so aesthetically oriented, so having the digital imaging package is part of that. Having access to, Matt Roberts contour, Lee Culp contour, all these unbelievable technicians that give me the tooth forms that I want when I'm doing my design was important to me. So again, if you're looking specifically at milling, I can certainly get you in alignment with a couple of doctors that we're working with now that are using the ThreeShapes and learning the printing and designs, but have also been milling in their office for a long time. But just understand that it's a big decision when you go down that road, because you're thinking about not only hardware, but you're also thinking about software and support and a lot of these other things.
Okay, thank you. The next question is, do you recommend, where did it go? Do you recommend a protrusive record to set the condylar inclination?
Such a great question. It depends on what I'm doing. It depends on what I'm doing. And similarly in the analog world, if I was doing a mounting to design restorations, I typically didn't take a protrusive record, because if we leave the condylar path at 20 degrees and we go ahead and design, like we're doing a full mouth rehab in a wear case, if we set the condylar path at 20 degrees and design our occlusion there, the condylar path in the patient will be steeper. So when we put those restorations in the patient's mouth, because the condylar axis is steeper, you're going to get faster posterior disclusion. So what Pete Dawson always said was, when we started to learn that anterior guidance was what we wanted, we didn't need to know as much about the condylar path anymore. It just had to be flatter than the patient. And so with that, a lot of times when I'm doing design, I just put it at 20 and keep moving. Now, if I'm doing a workup for like a trial equilibration, that's when I'll take a protrusive bite. And the way you do it in the analog world is you don't have to take a bite. You just put the teeth edge to edge in the patient, and you measure the distance between the posterior teeth with the perio probe. And on the virtual articulator, you protrude forward, and then you change the condylar path until that distance is the same. And so that'll allow you to get within range. So again, you can sort of work around this without having to utilize wax. But most of the time, I'm keeping my condylar path around 20.
Okay. Next, does the virtual articulator work with Exocad? Are you able to train with that software?
We're training completely with ThreeShape, but Exocad definitely has articulators and can do a lot of the same things. I just, again, find it a little bit, I just find the aesthetics contours not as desirable. I like the splint studio. We can design splints in ThreeShapes. It's so easy. It's a preference. So what I would just say, if you're in the realm, we can't train both. We've become experts, and Lee and I picked this particular software. We're experts at it, and that's the direction we're teaching doctors.
Okay. Is there a way to incorporate a Gothic arch tracing or central bearing point in a digital scan?
So if you think about it, if you're using a Gothic arch tracing, we will do that with our denture patients, but the Gothic arch tracing is really designed to get the centric. So, and I'll say it another way. The question may be actually, I think a bigger question, and this is something that's kind of coming now, is some of the jaw tracking devices. I mean, central bearing points are more this way, but there's jaw tracking that create all the movements that allow for sort of 4D type modeling of the jaw. And some of those things exist now. I did some testing with the CEREC product probably 4 or 5 years ago, and it was amazing. I mean, we could jaw track, we could take a CT, we could do the intraoral scans with the CEREC. And then what we would do is import the jaw tracking data with the scans into the CT, and the CT would actually move and you could see it. Very cool for teaching. But if you think about it, you had to have this CT, you'd have to, the Serona CT, their scanner, and it was like $400,000 worth of stuff to be able to look at the jaw move. It was kind of crazy. There's some hardware out right now that is in the $30,000 to $40,000 range that'll allow you to do it. I just don't think you need to do it. I mean, the thing about it is some of those dynamic movements we're talking about, we work that out in the provisional anyway. And so the way I look at this allows me to do everything I was doing in the analog world, and some of that precise information of how the jaw moves, as long as the posterior teeth exclude and the front teeth have anterior guidance and harmony envelope of function, I'm going to be stable. So I'm trying to keep digital dentistry as inexpensive as I can possibly do it. And I can warn you right now, there are a lot of like pretty bells and fancy things that you look at that you want that look really cool. But what you have to ask yourself, is it really going to allow me to do my job better? I think 4D stuff is coming, and there may be applications to it, but I don't think it's worth it right now for what the cost is. I think, getting good scanner, good printer, good software where you can do some of your own designs and things, you can make the complete leap to digital now and not compromise in any way.
All right, couple more. Is there a way to orient the angulation of the scan anterior posteriorly reliably, other than the CBCT? A sagittal photo or something similar to Coyce or Fox plane with a photo, perhaps?
Well, it's interesting. I'm anxious. I know Whitmix is working on something along those lines, prototype that I hope to see soon enough. Lorena's been talking to me about that. But I do think that there are, there's been some simple things I've used along the way, almost like a regular T-square. If you put a T-square on the edge of the central and you measure back to the condyles, you can get a number. And you can put a grid over the articulator in the software and slide that maxillary cast back and forth a little bit. I played with that a little bit to dial it in. So it doesn't have to be extremely complicated to get some of that data. My question though is, I don't know if it matters, because when I measure that exact distance, I'm always within 5 or 6 millimeters of 100 millimeters, it seems like. And the ear bow and the Bonwell point, which is what the Coy space bow is based on, it's plus or minus 10 millimeters. So we're within a 10 millimeters of that 100 millimeters average is amazing to me, because over the years in the analog world, I always found it to be accurate enough. And so again, the thing to worry about in the digital world, or the thing to think about in the digital world, if you are a really detail-oriented person like I am, it's sometimes you end up chasing numbers to chase the numbers that clinically may not be that important. And so if you think about it, if you're within 5 millimeters of here, what matters on the arc of closure is going from centric relation to maximum crispation, which is often like a 2 millimeter shift. How much does that really change where things actually land? Not very much. So I lost sleep over this when I started this. I thought about it and I was trying to measure and do all these things. And now I'm about 3 years in and I'm realizing, most of the time, when I set it 100 and I have my son put the edges on, it works. It's very, very predictive in what we're doing. I actually think too, that the other big accuracy in this is the fact that we don't have wax, and are trying to get wax to fit into stone models, and stone is not setting up, and we don't have mounting stone contract, all that expansion stuff. I just think when we scan in Centric and that comes in, I think that really eliminates a lot of the error that we've lived with and worked around over the years in the analog world.
Okay, is it possible to incorporate electronic pantographic tracing data into your system?
There's a lot of condylar gadgets out there, and honestly, kind of because of what I was trained for, I mentioned it earlier by Dr. Dawson. I just have always sort of believed I didn't need that data in the analog world. I don't really need it in the digital world, because again, I'm creating posterior disclusion. So I'm typically always studying my condylar path a little shorter than the patient. But I'm sure if you looked at the ThreeShape product, there's probably people doing things with axiographs and things like that and getting that data in there.
What do you think about patient-specific motion in Trios software?
I don't have the Trios. I think it's cool. I think, again, that is, again, another way to get data of how the jaw is moving that's specific to the patient. I think it's interesting from the standpoint of wear and tear and designing, particularly guidance angles and things like that might be appropriate. I think all this is moving towards some of that 4D kind of movement that we're all talking about here. What I'm really interested in to me, the thing that if I could have anything, I wouldn't care so much about knowing precisely what's happening back here. But if we could get jaw tracking data to give me specific envelope of function movements that were very predictable, so that when we brought in the anterior restorations, that the lingual contours of the maxillary teeth had that contours built into how the patient is moving, that interests me. Because I think once you're in centric relation and you establish anterior guidance, the thing that we struggle with, again, particularly docs that were trained by Pete Dawson, is getting the anterior guidance concave enough to be in harmony with the envelope of function. So to me, the big, silver tuna, if you will, on 4D is if we had a way to make smart wax ups that dropped in there that were in harmony with the envelope of function. And I think that some of the stuff that you're seeing with Trios and some of the other things, that's kind of where it's going. I think there's a little bit of a race there. All this is headed towards this the artificial intelligence, the AI stuff, which it's kind of freaky when you start reading about it, but I don't think it's a big stretch to imagine that we're going to be, scanning the patient's face, scanning their mouth, and the computer is going to be proposing things based on a lot of data, scanning the face, jaw movements, intraoral scans, all that stuff. It's pretty cool. But again, that's one of the reasons, again, with the community that we're sort of building, we kind of feel like that, building this community of people that are into this, Lee has the pulse of a lot of companies, but our goal is to just keep updating our site and the things that we do and keep everybody up to date what's happening.
I think we're on our last question.
Okay.
If a patient needs rehabilitation requiring information of posterior determinants, is a simple digital approach sufficient?
Absolutely. I mean, to me, when I go through what we're doing, all the information that we had in the analog world is there. I mean, there isn't anything different. We still have to use our brain. We still have to do mountings. We still have to determine contours. Still have to set vertical. But that face add method that I outlined, we're thinking about, again, skeletal things. We're thinking about arch form. We're thinking about vertical. We're thinking about stops. We're thinking about anterior guidance. We're thinking about posterior exclusion. All those things that we have to be thinking through to make sure teeth are where they're supposed to be cosmetically, phonetically, aesthetically. But it's also important to remember that there isn't anything in the analog or digital world where we can just determine it and it's 100% right. That's why we have temporaries. We're always putting the temps in the mouth, test driving in, making alterations, and our final restorations are always going to be things that we've adjusted. And again, in the digital world, what's so beautiful is we can scan those temps, take the temps off, scan the preps, and the lab can, put one over the other and copy precisely with what we've worked out in the mouth. It's just an exciting time. Again, it's stuff I've sort of dreamed about for the better part of 15 years, and we're finally here. And again, what's really cool is one of the people in this program that we're doing is my daughter, who finished school last year. And again, watching somebody young gravitate to this stuff is unbelievable because they've grown up with screens. I mean, they think more this way than I did. I had to learn analog and then apply it to digital. She's just learning digital, which is crazy. I didn't think it was possible, but I think they pick it up even faster. It's crazy.
Yeah, it is wild. It's an amazing time to be in dentistry, that's for sure.
Absolutely. Best time ever. Yeah.
Best time.
Sure. Mm-hmm.
So Dr. Kranum, thank you so much. What a fantastic webinar. Lots of great information. Thank you for the kind words about Whitmix and about our Vera One digital system. And thank you to all of you who stayed through the program. And I hope to see you at a future Whitmix webinar. So we'll see you all again. Stay safe and healthy. Thank you again, Dr. Cranham.
All right. Yeah, let me know if I can help anybody. Thanks. Appreciate it. Bye-bye.
Bye-bye.